That's what you get. Good evening. Hello and welcome, everyone. My name is Cheryl Osimo. I am the Executive Director of Massachusetts Breast Cancer Coalition and the Cape Cod Coordinator for Silent Spring Institute. To everyone in the room and to those watching remotely, we are so happy and grateful to all of you for joining us. Today, you are going to hear about initial findings of the Massachusetts PFAS and Your Health study on Cape Cod and what they mean for you and your family. I would like to thank Barnstable Town Manager Mark Ells for being here and for all that he has done to support this study and Silent Spring Institute from the very beginning. As a resident of Barnstable myself, it comforts me to know that our town manager truly cares for the health and safety of the community and beyond. Thank you, Mark, for welcoming us to Town Hall today to help us host this very important community event. Your unwavering support and deep commitment to the people you represent is truly impressive. Please welcome Town Manager Mark Ells.
Well, good afternoon, Mark Ells. On behalf of the town of Barnstable, welcome. Certainly, it's appreciated that you're having this community meeting here today to share the results of your PFAS study that you've been working on. And it's no coincidence that Barnstable has partnered with Silent Spring Institute for decades, given the core values that your organization and certainly the town of Barnstable possesses, in that any and all of us should be able to live safely and free from any sort of emerging contaminants that would be problematic, certainly, to us. This study looks into the drinking water supply and PFAS and certainly the health of our adults and our children in the community. It provides us with credible information to be able to go forward with decisions relevant to these sorts of concerns and others in the future. For those of you who are familiar with the town of Barnstable, quality of life is at the center of who we are and our certainly our values here, and our water resources are a critical part of that quality of life. So to be able to work together with a group like yours is greatly appreciated. I will note that Hyannis is now free of PFAS contamination, and it was a result of the leadership in this community taking prompt action as soon as it was identified, proceeding with, very aggressive remediation. But we are still concerned with emerging contaminants and the presence of those and the impacts that they may have on people's health now and in the future. So certainly the results of the study that they'll be speaking about in a moment are critical for our future decision-making, policy-making, and whether we achieve our core mission relevant to the quality of life that everyone here in Barnstable can enjoy. So thank you for coming, and I'll turn it back to Cheryl Osimo at this point. And thank you for allowing me to speak.
Thank you. Thank you, as always, Mark. And now I am honored to introduce Dr. Laurel Shader. Dr. Laurel Shader is a senior scientist at Silent Spring Institute, where she leads the Institute's water quality research on PFAS and other contaminants of emerging concern. Dr. Shader is the principal investigator of the Massachusetts PFAS and Your Health study. As many of you know, this important study is investigating the relationship between PFAS contaminants in drinking water on Cape Cod and their potential effects on human health. It's also part of a national health study of PFAS funded by the Centers for Disease Control and Prevention. Dr. Shader began studying contaminants in drinking water on Cape Cod shortly after she joined Silent Spring in 2009. As she was preparing to send her first batch of water samples from the Cape Back to the lab for analysis, she and her colleagues had the brilliant forethought to ask the lab to test the samples of PFAS as well. It turned out, to our surprise, that not only were PFAS widespread in Cape drinking water, levels in Hyannis were the highest in the state. We are enormously lucky to have been able to partner all these years with Dr. Shader, a talented and dedicated scientist and now world-renowned expert on PFAS in drinking water and everyday products, to help us address PFAS contamination in our community, to protect us from future exposures, and to work with town officials like Mark Ells to keep our drinking water safe. Please welcome Dr. Laurel Shader.
Great. Thank you so much. It's really a privilege to be here tonight. Thank you, Cheryl, for your kind introduction and for being a terrific partner for our work for the past 15 years since I started working at Silent Spring in 2009. It's thanks to your team at MBCC's incredible work to help us recruit participants for this study. I also want to thank Town Manager Mark Ells for his support over the years for our water quality research and all that he's done to protect the environment and public health here in Barnstable. And thanks to all of you for coming on this lovely, beautiful spring evening. And to those of you online, we will have opportunities for Q&A both in the room here and for those of you participating online. So tonight, or this evening, I'll be sharing preliminary findings from the Massachusetts PFAS and Your Health study. We're still in the early phases of analyzing the results of the study, but at this point, we're able to share a summary of the PFAS blood test results that we've measured for participants here in Hyannis who took part in the study. For individual participants in the study, you all should have received letters with your own results, and if you haven't, I'll share an email address at the end so we can be sure that you get your own results. So, hold on one second. This was working earlier. There we go. Great. So typically I do my acknowledgments at the end of a talk, but for this type of a study, this is such a tremendous undertaking and required the help of so many different people that I thought it was important to show and acknowledge the many people who've been a part of the team and helped us do this work. Some of our team is here in the room tonight, so many colleagues from Silent Spring Institute, our study coordinator, Emily Heckel, who'll also be asking the Zoom questions, and Emma Ryan, a research assistant, Abby Blind, who's a postdoctoral researcher in the back corner, and our partners at the Harvard School of Public Health from Eastern Research Group, including Neda Garellis, who's here tonight, and our collaborator from the University of Southern Denmark, Philippe Grandjean. It's been a privilege to work with the team from Massachusetts Breast Cancer Coalition, including Cheryl and Betty Ann Beavis and others who are instrumental in supporting our recruitment efforts. As you'll hear, our second community in this study was the town of Ayer, west of Boston, and so we worked with a community partner group there called PACE. And we're working with two hydrogeologists, including Tom Cambereri from the town of Barnstable, because part of our study is to reconstruct past levels of PFAS in the drinking water in order to estimate participants' cumulative exposure to PFAS from water over time. And I also wanted to acknowledge our amazing Hyannis field staff, including Joan Owens, who is our phlebotomist and made blood draws as pain-free as possible, and Virginia Liu, good to see you, as well as our airfield office team. Thanks to the hundreds of people who took part in the study. I know everyone's so busy these days, so I really appreciate people for taking the time to support the study and support the community as well. And then many other people supported the study. I don't have time to read everyone's names, but so many people who helped us by providing opportunities for us to recruit or coming with us to go door-to-door canvassing. I couldn't even fit everyone's name on this slide. So thanks again for everyone's support for this important work. So for this evening, I'm going to start with a brief overview of PFAS. I think some of you are quite familiar with PFAS, but others might be newer to the topic. So I'd like to talk a little bit about where PFAS can be found in our daily lives, what are sources of exposure, and what are the health effects that we know about that are linked to PFAS. I'm going to talk specifically about our Massachusetts PFAS in Your Health study, our goals and timeline, and the broader multi-site study funded and coordinated by the CDC that we're a part of. Then I'm going to walk through a summary of the PFAS blood test results that we've compiled for residents here in Hyannis who took part in our study. I'll walk through an example of a report back letter. So for those of you who are in the study, hopefully this will help provide more context to interpret your results. And for those of you who weren't in the study, it's an opportunity to learn a little bit more about how we interpret PFAS blood test results in general. And then I'll wrap up by talking about the next steps for our study and some key takeaways. So PFAS, when I started studying PFAS in 2009, PFAS were not in the news every single day. Now it's hard to open a newspaper or the news site online and not see an article about PFAS. PFAS is not just one thing. It's thousands of different chemicals that share similar chemical properties. The carbon-fluorine bonds that are kind of the hallmark of a PFAS chemical are extremely resistant to degradation. And so the chemicals don't break down as they move through the environment or pass through our bodies. And so they've been dubbed forever chemicals. They're very mobile in the environment. They've been found in ocean water and rainwater, in the blood of indigenous communities living in the Arctic, and polar bears and wildlife all around the world. PFAS aren't new. They've been used in consumer products since the 1950s. Think of those old ads for better living through chemistry, Scotch-guarded carpets, and Teflon pans. So you might wonder why it's just been in the past 10 to 15 years that they've gotten so much attention. I think that's due in part to community activism. If you've seen the film Dark Waters, you've seen a community in West Virginia impacted by a DuPont plant and the activism of a local resident who brought this issue to national attention. And it's also been through the discovery of PFAS in drinking water supplies all across the country that has really prompted a great deal of action and activism on this topic. I won't do a deep dive on the chemistry tonight, but I did want to mention two specific PFAS chemicals. The structures are in the upper right corner of the slide there. Those are PFOS and PFOA. These are both 8 carbon chain PFAS chemicals. That little blue zigzag in the middle is the carbon backbone. And these are what we call examples of legacy PFAS chemicals. So these are not actually manufactured in the US anymore, although there's still some global production. But they are still frequently detected in people's blood and in water. In their place, industry is now manufacturing other PFAS chemicals. Some of them are shorter chain, or they have different types of chemistries, but they raise the same concerns in terms of persistence and mobility and toxicity. So if you go to the store, you probably won't see PFAS on product labels, so it can be difficult to know which types of products contain PFAS. Generally, they're used in waterproof, stain-resistant, grease-proof, and non-stick types of products. So think of Gore-Tex jackets, Teflon pans, Scotch-guarded carpets and upholstery, Oral-B Glide dental floss, certain food packaging that's grease-proof, cosmetics, paints, guitar strings, rock climbing ropes. Really, they're pervasive in our everyday lives, and they're very difficult to avoid. So we can be exposed to PFAS in several different ways. So in communities like Hyannis, where there is a source of contamination close to the water supply, we can be exposed to PFAS through drinking water. We can also be exposed through food, both because of chemicals leaching from food packaging into the food that we're eating, as well as PFAS ending up in the plants and animals that we're eating because they can absorb them from their environment or they can move up the food chain. We can also be exposed through consumer products as well. There can be potentially absorption of PFAS through the skin, transfer from hand to mouth, especially for children. There's definitely a concern about exposures because kids put their hands in their mouth a lot. They're close to the ground. Everything's going in their mouth. There are also some PFAS that are volatile, so they can end up in the air that we breathe in, and they can end up in dust. We all inhale or ingest a small amount of dust each day as well. One of the most common sources of PFAS contamination in the environment is a class of firefighting foam called AFFF, which is aqueous film-forming foam, also known as Class B foams. These are used to fight and train for fuel fires or liquid fuel fires. So, for instance, they are commonly found in groundwater near airports, military bases, and other fire training areas where firefighters use these for training or for emergency response. I'll also mention that the waste stream can also be a source of PFAS, so wastewater treatment plants, septic systems, landfills, and land-applied sludge or biosolids also can be sources of PFAS into the environment. So for all of these reasons, the widespread use of PFAS in products, their persistence and their mobility, exposures to PFAS are common. According to testing conducted by the CDC, over 99% of people in the US have PFAS in their blood. This is through testing as part of the study called NHANES, which I'll talk about in a little bit, a representative sampling of people in the US. Some PFAS can stay in our bodies for years, particularly those long-chain PFAS like PFOS and PFOA, which it can take years for the amount in our blood to go down by half after we stop being exposed. The newer PFAS chemicals tend to have not such long time, what are called half-lives in our body, but they still can stay in our bodies for weeks to months even after we stop being exposed. And many PFAS haven't been tested to evaluate their half-life. So there are some predictors for whom it might be expected to have the highest levels of PFAS in their blood. So age is one determinant. So among adults, we generally see that older adults tend to have higher levels of PFAS in their blood than younger adults because the PFAS can accumulate in our bodies over time. For children, we can sometimes even see an inverse relationship where younger children and infants may have higher levels of PFAS from pregnancy and breastfeeding because we know PFAS can get passed along in early life. Gender, or more accurately, biological sex is also a determinant of PFAS. In general, men have higher levels of PFAS than women. So PFAS bind to proteins in our blood. And so through menstruation, also through pregnancy and breastfeeding, PFAS can be lowered in women's bodies. This difference is less noticeable in older people because of postmenopausal women don't have that lost pathway of PFAS from their bodies. And then occupation also can be a predictor. So for people who work in industries that manufacture PFAS or create PFAS-containing products, they can have high exposures. Even ski waxers can have high PFAS from fluorinated ski waxes. And there are concerns about firefighter exposures, both from firefighting foam and from the protective gear that they wear that has a PFAS-containing layer. And all of this is concerning because there's an extensive body of evidence that PFAS can affect our health in many different ways. For instance, PFAS exposures have been linked to increased cholesterol and risk of obesity. Some of the strongest evidence that we have is related to immune system suppression, specifically reductions in antibody production in response to routine vaccinations in children. There can be changes in thyroid hormone levels and thyroid dysfunction, reproductive effects such as preeclampsia, which is high blood pressure during pregnancy or decreased fertility, developmental effects, so decreases in birth weight or changes in bone density. Silent Spring Institute focuses on environmental causes of breast cancer, and so we're concerned about laboratory evidence that PFAS can impair mammary gland development because we think that it could be a marker of increased breast cancer risk. And then certain types of cancer, including kidney and testicular cancer, have also been linked to PFAS exposures. So there's a lot that we do know about how PFAS can affect our health and plenty of evidence that we should take action to reduce people's exposures. But there's a lot that we also don't know. And so I've worked for many years in Cape Cod, but also in communities across the country that have experienced PFAS contamination. And I often hear from people who've been exposed that they want to be part of health studies. They want to create new knowledge so that we can do a better job of protecting the next generation. So I'm going to talk a little bit now about the history of PFAS in the Hyannis water system. So as Cheryl mentioned, Silent Spring Institute was the first to test for and find PFAS in drinking water in public water supplies on the Cape. And from that work, we saw that the levels in the Hyannis water system were higher than other water supplies across Cape Cod. We don't know when PFAS first got into the drinking water. In Hyannis, those PFAS-containing firefighting foams started to be widely used in the early 1970s. So we think that it was probably in the 1970s that those PFAS might have first gotten into the drinking water supply. The EPA, even though they only started regulating PFAS just a couple of months ago in drinking water, did require large water supplies to test for PFAS back in 2013 to 2015. And through that testing, it was revealed that the levels of PFAS in some of the wells in Hyannis were higher than in any other water supply in Massachusetts. The main sources are those firefighting foams, which were used at the Barnstable County Fire and Rescue Training Academy. They're also used at the Barnstable Municipal Airport, which I guess is now called the Gateway Airport. So it's really important to note, and as Town Manager Els said, the Hyannis water system has been treating for PFAS for quite a while. So starting in 2016, Hyannis began filtering PFAS, filtering the water to remove PFAS. And there have been a series of guidelines both at the federal and state level and now drinking water standards. And so the Hyannis water system has ramped down the PFAS in the water over time to meet those guidelines and standards. So it's important to emphasize that all Hyannis water right now is filtered to filter out the PFAS. So that's important to keep in mind, but because of the past exposures and because we're concerned about chronic long-term exposures and how those can affect our health, it's important to do this type of research in communities such as Hyannis, where we can learn from the past exposures to better protect the next generation. So now I'd like to talk more specifically about the Massachusetts PFAS in Your Health study and the broader multi-site study that we are a part of. So the broader study is called the Multi-Site Health Study. It's funded and coordinated by the Centers for Disease Control and Prevention and from the Agency for Toxic Substances and Disease Registry, or ATSDR. I'm happy that two people from ATSDR are with us tonight, Tara Summers and Chris Mugford. And if anyone has questions for ATSDR, you can ask them. The broad goal for the PFAS multi-site health study is to better understand how exposures to PFAS from drinking water can affect our health. Back in 2019, ATSDR put out a call for proposals for research teams to work with local communities to be part of this broader study. A lot of communities like Hyannis that have been impacted by PFAS are pretty small, and so it's hard to do a big health study when there are only maybe a few thousand or 10,000, 20,000 residents in a community. The goal for the multi-site study is to pull together results from many different communities that have had PFAS exposures, and that gives us more ability to learn more than studying individual communities one at a time. So broadly speaking, the target for the multi-site study was to recruit 7,000 adults and 2,100 children, and the ATSDR funded 7 research teams in the states that are shown on the map, and Silent Spring Institute our proposal was selected for funding, so we're one of the 7 sites within this multi-site study. So our study has 2 communities, Hyannis, where we had long been doing research and where previous testing had shown relatively high levels compared to other water supplies in the state. Around the same time, we were getting to know our partners, or now our partners in Air, which is another community where the public water supply was contaminated by the use of AFFF firefighting foam, in that case related to the former Fort Devon site. So our study includes the 2 communities, and our goal was to recruit 1,000 adults and 300 children, ages 4 to 17, across both communities. And this was a goal that ATSDR had set for each of the 7 sites. And our recruitment included both current as well as former residents, specifically of Hyannis Village, because the sort of central organizing eligibility criteria had to do with the Hyannis water system. So I've learned a lot by doing the study, and one is that to recruit people for a major health study takes a tremendous amount of work and the involvement of many people. So we tried many different approaches to reach out to people in the community in a lot of different ways. We sent multiple rounds of postcards to all Hyannis addresses. We had informational tables at local stores, at the mall, at all kinds of community events. We printed lawn signs and posted them around town. We did door-to-door canvassing. We engaged with community leaders and held events at our study offices and in the community. We were grateful for media coverage, for instance, from the Cape Cod Times and other news outlets here on the Cape. We're grateful for the help from the town of Barnstable to help get the word out to the community. And then through Silent Spring and MBCC social media and through our studies social media channels as well. And this is not complete, but I just wanted to convey that it's really a big effort to get the word out for a study such as this. So I'll talk a little bit about the eligibility and the components of the study. So to be eligible for the study, adults needed to have lived in Hyannis anytime between May 2006 and July of 2016. So you might wonder, where did those two dates come from? So the second date, the July 2016, was related to the installation of water treatment. So to be eligible, people had to have lived in Hyannis when the water was still exceeding the EPA guideline set in 2016 of 70 parts per trillion for PFAS and PFOA combined. So after that point, all the Hyannis water fell below that level. So people had to have lived here before July 2016 to be eligible. At the same time, we also are relying on measuring the PFAS levels in people's blood as a way to evaluate their exposures. So if someone had lived in the community 50 years ago and hadn't lived there since, their current PFAS blood levels wouldn't really tell us much about their exposure. So people had to have lived in the community within about 15 years before we started the study, and our study was launched in May of 2021. So that's where we got the May 2006 date. For children, the eligibility criteria were similar. They had to have lived in Hyannis themselves, or they could be eligible if their mothers lived in Hyannis during that period of time before the child's birth. Again, PFAS can be passed along during pregnancy and breastfeeding. A couple of other notes. So people didn't have to have lived in Hyannis at the time of the study to be eligible, as long as they lived there during that 2006 to 2016 window. And as many people within a household could take part as long as they were each individually eligible. Because the focus of the study was on exposures from drinking water, and a component of our study will include estimating past exposures from water, the study did not include people who might have had high exposures from their jobs, for instance, firefighters, or people who had worked at PFAS industrial facilities. So just to give you a sense of what it was like to be a participant in our study, so for people who called our study office or contacted us, we did a quick screening questionnaire to make sure they met our criteria. Then they came to our office for an office visit. We first had a clinic on Main Street, just east of downtown here, and then the building was being renovated. So then we did have to move to a second location on Falmouth Road, just over the line in Centerville. So when people came to our office, we went through an informed consent process with them. We asked them to provide a blood sample and a urine sample, and then we collected body measurements. Some were pretty routine, like height, weight, blood pressure. We also used some more novel methods, such as a special scale called a Tanita scale, which tells about body composition. After that, we scheduled a time for a questionnaire that we did by phone, where we asked where people had lived and worked over time. We asked about their water consumption, again, because we're going to estimate past exposures for each participant from the water. Our site also added questions about diet and consumer products to learn about other ways that people may have been exposed to PFAS. And then we asked some questions about health history, some medical conditions that people might have had, as well as medications that they're taking. And then for children ages 5 to 17, we asked their parents or guardians to bring their children back for a second visit for a series of neurobehavioral tests. And these were intended to assess executive function, attention, and IQ. And so what are we testing for as part of this study? So blood samples from each of our participants were sent to the CDC laboratory in Atlanta, where they were measured for the levels of 7 different PFAS chemicals. We also conducted some more routine lab tests, so some things like cholesterol, blood sugar, thyroid hormone, liver enzymes, and other more routine lab tests. And then for some of our participants, we'll be adding on some additional analyses as well. We are going to test for some additional PFAS beyond the 7 that are being tested by the CDC lab. We're doing some what are called metabolomics analyses. So this tells us about how PFAS can alter biochemical pathways. So this tells us more about how exactly PFAS are acting as toxic chemicals in our bodies. And then we're also measuring COVID antibody levels, again, because of questions and concerns about immune suppression. So to put this all into a context of the timeline for the study, so we found out in September of 2019 that we were awarded a grant to be part of the study. Then COVID hit, so that was a major challenge for the study. And obviously, the CDC and ATSDR had some challenges as well. It was a very busy time. So it took a while to get the study really underway. So after about 2 years, in September 2021, we had the approval for the study protocols, and we were able to launch enrollment shortly thereafter here in Hyannis. We launched enrollment in AIR a year later. We kept going in Hyannis to come as close as we could to our target. And then last September, all 7 sites were required to wrap up data collection so that we could move on to the next phase of the study, which is now analyzing the results. And so we're having a pair of meetings. We already had a meeting today at noon to share this initial update about the PFAS blood test results here in Hyannis. We are going to have a meeting next week, Thursday night on June 13th in AIR. There will also be an option to join that meeting remotely as well, where we'll focus on the AIR community results. So in terms of our enrollment, how did we do compared to the other sites? So this graph shows the enrollment numbers at the end of September when we wrapped up data collection. These are not exactly the final numbers, but it gives you a sense of how our site in the middle compared to the other sites. And overall, given all the challenges and given that our community is quite a bit smaller than some of the other communities, I'm really proud of how much we were able to accomplish. We had almost 700 adults and almost 100 children who took part in our study across both of our communities. Looking specifically at the numbers for Hyannis, we screened almost 600 adults and 77 children, or rather their parents or guardians. Not everyone who got screened was eligible, and not everyone who was eligible was able to actually take part in the study. But in the end, we had almost 400 adults and 41 children in Hyannis who provided blood samples and completed questionnaires for the study. So now I want to walk you through the preliminary findings from the blood test results that we've received for participants here in Hyannis. So first I wanted to just talk a little bit about the population of people who took part in our study. The median age for adults was 62 years of age. So we definitely had a above average or an older study population compared to the general population. Our children ranged in age from 4 to 17, so the median was right in the middle there, 12. For adults, we had more than twice as many women take part in the study as men, but for the children, we had a more even distribution between boys and girls. For adults, the vast majority of our participants were non-Hispanic white. We also had a good number of Hispanic, non-Hispanic Black, and other non-Hispanic residents as well. And for children, we had a slightly more diverse population, still a majority of non-Hispanic white participants, but also Hispanic and non-Hispanic Black resident participants as well. So before I get to the next slide, which has a table with a summary of our data, I just wanted to touch on a couple of key terms. So I already mentioned median. So probably know a median is sort of a middle value. So for age, median age means half of the people are older and half the people are younger. For blood results, the median result means half the people had a higher level, half the people had a lower level. Minimum means the person with the lowest level, maximum is the highest individual level, and the 95th percentile indicates the level above which people fall in that top 5% of the overall population, and 95% of people have result below the 95th percentile. So I know this is a complicated table. I'm going to walk you through it. A couple of notes before I do that. The units, so all of these numbers are representing a concentration of PFAS in blood serum, and the units are micrograms per liter, which is the same as nanograms per milliliter, which is the same as parts per billion. So there's kind of three different ways you can say the same thing. Where you see a less than 0.1, that means that that was a person where that chemical was not detected above the laboratory reporting limit of 0.1 parts per billion. So what we're showing here are the 7 chemicals that we tested for in people's blood samples. And the second column there shows the percent of people that had this chemical detected in their blood. So there were 4 chemicals that were found in nearly all participants. So PFOS, which we saw on that earlier slide, PFHXS, which is a related chemical, slightly shorter chain version of PFOS, PFOA, which is C8, which was also a chemical I mentioned earlier, related to Teflon manufacturing, and then PFNA, which is similar to PFOA, but with 9 instead of 8 carbons. So most of the graphs after this will focus on these 4 PFAS because these were the ones that were found most frequently in Hyannis. I would say the same is true of the general population. These are the ones that tend to show up most frequently all across the country. For communities such as Hyannis, where the main source of contamination is firefighting foam, in general, PFOS and PFHXS are the 2 chemicals that tend to be most elevated compared to the general population. So what I'll show here is that PFOS and PFHXS were found at the highest levels compared to the other PFAS chemicals we looked for. So they had the highest median, the highest 95th percentile, and also the highest maximum level. So some of the graphs now, I'm just going to focus on PFOS and PFHXS. So we wanted to know whether we saw similar trends with respect to age and sex as we might expect in the general population. So we did find that PFAS levels in Hyannis did increase in adults with age. So we saw that for people ages 65 and older, their levels on average were about 3 times higher than people who were 18 to 44. We also compared our child participants, so ages 4 to 17, to adults, and we did see that the levels in adults were considerably higher than for children. So for PFOS and PFHXS, the levels were about 3 to 4 times higher in adults than children. For the other 2 chemicals shown here, PFOA and PFNA, the adult levels were still higher, but it was more like a 1.7 to 2 times higher difference. And then in our Hyannis participants, we did see that the levels in men were slightly higher than for women. In the general population, we tend to see a bigger difference between men and women, but again, for postmenopausal women, we tend to see fewer differences between men and women in that older age range. And since our participants tended to be older, we think that's why we didn't see such a difference here between men and women as we tend to see in the general population. So then the next question that we wanted to answer was whether the levels that we saw here in Hyannis were higher than we might have expected in the general population. So you might wonder, well, how do we know what PFAS levels are like in the general population? And the most reliable place to go for sort of a representative sampling of the general population is a study that's conducted every 2 years by the CDC called NHANES. So this is the National Health and Nutrition Examination Survey. So this is a representative sampling of around 5,000 US residents that takes place every 2 years. It's much bigger than just PFAS. It focuses on diet, there's questions about nutrition, and they do measurements of lots of different everyday chemicals, not just PFAS. But PFAS were included in the most recent cycles of NHANES, and there were about 2,000 people who were included in the 2017 to 2018 round. You might wonder if there is any more recent data than that. The 2019 to 2020 cycle hit a major challenge with COVID, and so my understanding is that there will be sort of a grouping of 2019 to 2022 or 2023 to include the years where there was an interruption for COVID. So this is important to keep in mind that the samples, the data that we have for the general population are a few years earlier than the samples that we collected for our study. And this is important to keep in mind because in general, levels of these 4 PFAS have been declining in the general population. And that's because 3M and DuPont agreed to stop making these chemicals in the early 2000s. And so we can see that when we reduce exposures to these chemicals, that the levels in people's blood do go down. PFAS started at the highest level, so you can clearly see that decline. But PFHXS and the other chemicals also have been declining in the general population. So we don't have more recent measurements than the 2017 to 2018 cycle, but we can estimate that the general population levels should be lower now than they were during that cycle because of this downward trend in declining exposures. So this is another graph, I'll walk you through this, where we're comparing the median values for Hyannis, shown in blue, for our other community, air, shown in the yellowy orange bars, and from NHANES, so for the general US population in the gray bars. And before I explain the numbers, I wanted to make a note that these are adjusted for the age distribution of our participants. So if you imagine a community that didn't have any drinking water contamination, but had the age profile of our participants, so an older population, you would expect that even without any water contamination, that we would see higher levels of PFAS in people's blood simply because they're older. And we saw earlier that older people tend to have higher levels. So in order to do a like apples for apples comparison, we adjusted the values to take into account the age distribution of our study population and adjust that statistically to kind of make that match the age distribution of NHANES. So that any differences that we see shouldn't be related to the fact that our study population was older and just should be related to any differences in exposures. So I'm going to start with PFHXS because this was where we saw the biggest difference between Hyannis and the general population. So we saw that the median PFAS level in Hyannis was over 3 times higher than the median for the general population. We also think that because the general population values were from 2017 to 2018, whereas our participants took part in the study from 2021 to 2022, that gray bar in reality might be smaller. So there might actually be a bigger difference, but we don't have those national results yet for a quantitative comparison. For PFOS, we did see that the Hyannis median was slightly higher, so about 10% higher than the general population. Again, in reality, that gray bar might be lower if we were looking at the exact same time period. And then for PFOA and PFNA, we saw that the levels both in Hyannis and air were pretty similar to the general population. And that was also true for the other 3 PFAS chemicals that aren't shown here that I showed on that first table that were detected less frequently in our study participants. So that provides an overview of our findings at a community level for Hyannis. I wanted to talk a little bit now about the results that individuals have received and provide some information about how to interpret individual PFAS blood test results. So for people who took part in the study, they received a packet with results. So there was a cover letter to provide information about the study and what was included in their reports. There was a page with their actual results. And so this is pulling out the table with each participant's, an example of each participant's results. And then we did provide some additional information to help interpret the results. So I'm just going to walk you through this. So what we're showing here are the results for 7 individual PFAS chemicals. These are the ones we already saw on the previous table. So this is showing the individual's result, again, in parts per billion, micrograms per liter, nanograms per milliliter. We provided information from NHANES for the appropriate age group. So this is for an adult participant, so we're showing NHANES participants who are 20 plus. For children, we used NHANES data from children instead to provide a more comparable comparison group. What we're showing here from NHANES are the median and the 95th percentile values for the general population, and we highlighted where people's values fell above the 95th percentile for the general population. We also calculated the sum of these 7 PFAS so that we could compare the results to a National Academies report that provided benchmarks for medical screening based on the results of PFAS blood tests. So back in 2022, a study panel put together by the National Academies published a report on guidance on PFAS exposure, testing, and clinical follow-up. So the goal was to provide recommendations for clinicians and improve patient care for patients who had questions about PFAS exposures. So the report made a very strong recommendation, and it was kind of the first time that a national level organization made a strong recommendation that clinicians should offer PFAS blood tests to patients who wanted this type of testing if they were likely to have elevated exposures. And this was really informed by input from members of PFAS impacted communities who made a very strong statement that they wanted access to this type of testing, that they wanted to have this information, and they saw that knowing about their exposures would empower them and help them take action to better protect their health. The study also made recommendations about additional clinical screenings or lab tests that clinicians could consider based on the results of the PFAS blood test results. So the National Academies report came up with 3 general categories to help people interpret the results of their PFAS blood tests. So you add up those 7 PFAS. For people who fell in the first category, so less than 2 micrograms per liter, the National Academies report concluded that harmful health effects were not likely. I will say that even in the general population, almost nobody falls in this category, even without local environmental contamination, given all the ways we can be exposed through products and food. It's very difficult to have low levels of PFAS to fall in that category. Most people in the general population fall in this middle range of 2 to 20 micrograms per liter of PFAS in their blood. And for this range, the National Academies recommended that clinicians should conduct some routine screenings that for the most part, are part of routine medical care anyways, such as testing for dyslipidemia, so high cholesterol or triglycerides, once for kids and then for adults as well. Things like screening for high blood pressure in pregnant women and screening for breast cancer. And the National Academies concluded at this level that there might be some elevated risk for certain types of health conditions. And then for people with levels of 20 micrograms per liter or higher, the National Academies had some additional recommendations for tests or screenings that clinicians might consider for their patients. So in the general population, as I said, almost nobody falls in that low category, and about 13% of people in the general population fall in that over 20 category. What our results indicated was that for in Hyannis, that that the proportion of adults that fell over 20 micrograms per liter was about 3 times higher than in the general population. And that reflects the higher levels of PFAS that we previously saw in Hyannis participants. As part of the report back packages that we sent to our participants, we also included resources for clinicians and patients. These were developed as part of a separate study that Silent Spring Institute is leading called PFAS Reach. Our research team worked with clinicians to develop a series of medical screening guidance documents. We put this together before the National Academies report, basically looking at the scientific evidence for harmful health effects and making recommendations for the types of tests that clinicians may want to consider for patients with elevated exposures. We also know that doctors often haven't heard of PFAS. PFAS are a relatively new concern, and so we wanted these resources to be educational and help foster productive conversations between patients and their healthcare providers. So for people who weren't able to take part in our study or would like to know about their PFAS blood test results, there are some options for people who want access to this type of testing. In some cases, people are able to access PFAS blood testing from their healthcare provider. Other times, healthcare providers aren't able to offer this testing, and insurance often may not be able to cover this testing. It can be a little bit dependent on your doctor and on your insurance. If for people who are interested in doing this on their own, there are a couple of options that are out there. Doing a test on your own costs usually somewhere around $250 or $300, so it's not an option that is accessible for everyone. But for people who are looking for this type of option, we have information on our PFAS Exchange website. You can scan that code there. We provide information about how to access blood testing and some considerations if you're looking into getting your blood tested for PFAS. And we also provide information about laboratories that work with individuals. So there's one test that you can actually do at home. It's like a finger prick test. So you can do that at home without needing a phlebotomist, and you can send the kit back in the mail. And then Quest Health is now offering options where some of their local patient service centers will work with individuals to offer PFAS blood testing. So if you're looking for more information, again, we have information on the PFAS Exchange, and you can scan that code. And really, for people who've had elevated exposures, there's not much that can be done to really accelerate the rate of loss of PFAS from our bodies, but it's important to try to reduce additional exposures moving forward. And there are things that all of us can do to try to reduce exposures to PFAS in our daily lives. So selecting products, when possible, without stain resistance or water resistance, avoiding microwave popcorn, and trying to eat more fresh food, which is a good advice in general, to minimize contact between food and food packaging, avoiding cosmetics and other personal care products that have ingredients with fluoro in the ingredient list, minimizing contact with fluorinated ski waxes or floor waxes. And they're not easy to find, but some products will actually say they're PFAS free, so you can try to find those types of options. And it's important it doesn't just say like PFOA free, because all that means is that it doesn't have PFOA, but it could have any of the other thousands of PFAS. So you want it to say PFAS free. And in general, for tips for reducing your exposure to everyday toxic chemicals, you can download Silent Spring Institute's Detox Me smartphone app, which provides science-based tips for reducing exposures to PFAS and other everyday chemicals of concern. So to wrap up here, I'm going to talk about the next steps for our study and some key takeaways. So the next steps for our study, so we are working really closely with our partners at ATSDR and with researchers from the other 6 sites to first compile the data from all of our participants and ultimately work towards evaluating associations between PFAS levels in people's blood and health effects. And this is quite an intensive process. There are a lot of things that you have to account for in those statistical analyses to make sure if you're seeing an association that as much as possible it's likely to be related to the chemicals and not some other factor that hasn't been considered in your statistical analysis. For our participants here in Massachusetts, we are conducting some additional analyses, as I mentioned, so we're looking for some additional PFAS chemicals and running COVID antibody tests for some of our participants. We're in the process of reconstructing past water levels. We're working with hydrogeologists and compiling information where we can about likely levels of PFAS in the drinking water over time. And we're going to use that information to try to reconstruct blood PFAS levels for each of our participants back in time. Because when we look at someone's current PFAS blood level, that's kind of a snapshot of their exposure in recent years, but it doesn't help us distinguish someone who maybe lived in Hyannis for a really long time compared to someone who moved here more recently. And we plan to provide updates to the community over time as we have new results to share. So some key takeaways just to wrap up here. So I want to emphasize that this multi-site study is a really big deal. It's a very visible national study. There are thousands of people who are taking part in the study all across the country, and it provides some really unique opportunities for us to learn more about how PFAS can affect our health, the levels of exposure that can be harmful, and how we evaluate mixtures of different PFAS, because we know we don't just get exposed to one PFAS at a time. Another key takeaway from our results, specifically in Hyannis, were that the levels of two PFAS chemicals, so PFHXS and PFOS, were higher in Hyannis residents compared to the general population and also compared to our participants in air. And this is consistent with the fact that the levels of PFAS in Hyannis water, back when the levels were elevated, those levels were higher than the levels of PFAS that were in the air public water supply. And our analysis of the data is ongoing as we seek to understand how PFAS can affect our health. And the results of this study may inform future regulations as well as improve clinical guidance in the future. So with that, thank you again for coming. That's my contact information. If you were a participant in the study and you didn't get your results, that's our email address. So please do email us, and we'll make sure that we get a letter in the mail to you with your correct address to get you the results. Or feel free to contact us if you have any other questions. So with that, we can move to the Q&A session. We do have a survey. We would really appreciate your feedback on tonight's session. You can take the survey on your phone with the QR code. We also have some printed copies, so you could fill one of those out on your way out. So thank you, and looking forward to your questions. All right.
Thank you, Dr. Shader. So we'll entertain questions. We'll take one from the audience first, and then we'll move to take a question from someone in Zoom. Please.
Yeah, please speak into the mic so that our listeners at home can hear the questions.
Is that on? Yes.
That's on.
Yeah, you showed in that one slide that the participants here in Hyannis had about a 38% more to the population, whereas other areas were about 7%, something like that. Did you find that in all of the other areas in the nationwide study? You said we were higher than air, but was that roughly the same throughout?
So far we've been analyzing the results for our site, so I don't have the results for the other sites yet. So I would have to get back to you about that when the other sites are at the same point with analyzing their results. I will say that here in Hyannis, the PFAS that stood out most from the water testing results and the blood testing results were PFOS and PFHXS. In other communities, there were other types of pollution sources. So where there were more industrial sources, those communities had higher levels of PFOA and PFNA. So they might be higher in other PFAS, and Hyannis might be higher in those too. Compared to other studies that have previously been tested for PFAS, I would say that the results for Hyannis do kind of fall in the middle. There are communities that have had higher levels, higher median levels, in areas with much higher PFAS in the drinking water, and then some other communities that have had lower median levels.
And the second question, you talked about the future, the health outcomes. When do you expect to see some of that? I mean, was there some of that available when you sampled folks that already were having health outcomes that they think were related, or how long is that going to take to do that piece?
That is a good question. That is definitely going to take a longer amount of time as we work with the other sites to compile information. There are some parts of the study where we're running tests just for our participants here in Massachusetts, and so I anticipate that we'll be able to complete those more quickly. The coordination with the other 6 sites, as well as with the PEAS trade port, which has been folded into the multi-site analysis, will take longer. I don't know exactly when.
Okay, we'll take a question from someone in Zoom. Emily?
Sure, thank you. I'm just going to try to combine a couple of questions because we've got a bunch coming in. But related to the question that was just asked, we have a question that says, if the results, if your PFAS test results show that you have high levels of PFAS, does that mean you're guaranteed to be more likely to experience the negative effects described in the presentation, the health outcomes? And then also, are the short chain PFAS or the newer PFAS, are those any better for us than the long chain PFAS in terms of those health outcomes?
Great. Two great questions. So the first is for people who have elevated PFAS in their blood, what does that mean for their health? And I guess I think about it in the same way that when you get your blood tested for cholesterol, if you have high cholesterol, it doesn't mean that you will necessarily have a cardiovascular disease, but it means you might be at greater risk. So in the same way, people who have higher PFAS in their blood may be at greater risk of certain health effects related to PFAS, but it doesn't necessarily mean that any of those would necessarily happen to you. And it also can be difficult at an individual level. So for people who have a disease that's on the list of things related to PFAS, there's no way to know at an individual level if someone's health condition is specifically related to their PFAS exposure. We can really only make those assessments at a community or population level. In terms of the short chain PFAS, are they better? Are they safer? I think we have, at this point, a lot less information. We do know that they are similarly persistent. We also know that they are even more mobile in the environment. The information that we have now indicates that they are less persistent in our bodies, so they don't stay in our bodies for years, but they do still stay there for weeks or months, and we are exposed all the time because these are chemicals in products. So just because a chemical doesn't stay in your body for a long amount of time doesn't mean that it isn't harmful. From the information that we have so far, it seems that the short-chain PFAS have been linked to the same types of health effects as the long-chain PFAS, although it seems like they are less potent. So that means that we don't seem to see the same effects at the same low levels of exposure that we do with the long-chain PFAS. But I would add that for the long-chain PFAS, our understanding of health effects at lower and lower levels has been evolving, and so we may learn similar lessons for the short-chain PFAS over time. Just for the people on Zoom, they won't hear you if you don't use the mic.
Can you hear?
Yeah.
I just wanted to know if you would come back and if you have any plans to come back and see if our levels, I was tested, if they are increasing or decreasing or where we are going in the future. Is that something that...
I think that's an important question, and I would like to have the opportunity to do some sort of longitudinal studies, so looking over time, both at how levels change in people's bodies, as well as to do more longer-term health follow-up. Currently, we're not funded to do additional follow-up, but that is an important question and something that we would like to consider. Definitely, if we were able to do follow-up, we would recontact people because then we would have that initial baseline and we'd be able to look for changes, yes.
Okay, another question from Zoom, please.
Sure. This question is about donating blood. If you have PFAS in your blood, does that affect the blood that you might donate, and should you continue to donate blood if you have elevated PFAS levels?
This is another really good question, and I was at the National PFAS Conference a couple of years ago, and there was an extended discussion on just this question. So the idea that PFAS bind to the proteins in our blood and the fact that women generally have lower levels related to menstruation has raised questions about, if you donate blood, does that lower PFAS in your body? And there was a study of Australian firefighters that did show that blood donation or plasma donation could lower the levels of PFAS in their blood. It's a really good question, like what do you do with that blood? In general, we don't really test blood for most things before we donate. So we don't have any guidance really about a level above which you might not want to donate blood. My initial reaction would be that when you are receiving a blood donation, that the most important thing is to have blood to a blood available. So I think that for that sort of emergency response, that I guess I wouldn't worry as much about the PFAS unless you're really receiving blood donations all the time. And I think if you have some people of high PFAS in their blood and other people of lower PFAS, that it would sort of average out. But I think it's one of the challenging dimensions of PFAS, because we shouldn't really be worrying about toxic chemicals when we're talking about something like donating blood and helping protect people's or preserve people's health.
Sorry, looking the wrong way. Hello. By the way, I read an article in the New Yorker recently that was all about this, called "You Make Me Sick." So that might be worth looking at if you want to follow up on this. It was pretty good. But my question is this. Do you see a correlation between the types of PFAS chemicals that have appeared in your blood test samples and the firefighting foam that appeared as a pollutant of our water supply?
So the PFHXS and the PFOS are the PFAS that are most commonly, or in the past, have been found in firefighting foams, and those were found at the highest levels in the Hyannis water supply. So it's not surprising that those were the PFAS that were most elevated in our participants.
Sure. Another question related to firefighting foam. What is the difference between AFFF and ARAFFF, and were both used in Hyannis?
I don't want to misspeak, so I don't know if I know what ARFF is. So I might not be able to answer this question specifically. I'm looking at Abby because I'm not sure. I could get, so I don't know if I can answer this question. I will say that there are fluorine-free foams that are available, and there's a movement away from PFAS-containing foams, not just moving away from long-chain PFAS, but PFAS as a whole, so that we're not playing this game of whack-a-mole with switching from long-chain to short-chain and trying to swap our way out of using not using one PFAS we know is harmful and switching to another PFAS, only to later find that those are harmful as well. In the past, there were barriers to moving away from PFAS-containing foam. For instance, the military had a specification called the MIL spec, which actually required the use of PFAS-containing foam. There was no way to meet the standard without PFAS. And that standard also trickled down to the FAA, so the Federal Aviation Administration, and so that trickled down to airports also being required to train and have PFAS-containing foam on hand. And so some of those requirements have been shifting, and there's now more under federal regulations, there's more ability for firefighters to train with water or to move towards fluorine-free firefighting foam. But there's still PFAS-containing foams that are being used.
I used to have this job when I was in high school, when we were actually a town. We used to be a town form of government. We had town meeting, and someone had to hand the microphone. So first, quick comment, just following up on what you just said exactly, Dr. Shader, because that was one of my questions, but you basically answered it, this thing with the FAA, because recently I was sitting at a breakfast meeting, and one of the members of our airport commission and I had a little disagreement about the PFAS-laden foams that our Barnstable Municipal Airport is still using. And they are owned by the government of Barnstable. They're not an independent airport. The new name kind of gives you that false impression. So they are still using foams, but you just clarified, apparently because the FAA is requiring that? Is that the FAA is requiring the use of PFAS-laden foams still in airport applications? Ah.
There's an effort to kind of change that letter.
Okay. Yeah.
Now it's an option.
Okay, so
With PFAS or not.
thank you for that explanation, because we have two of the city councilors sitting here, Councilor Clark and Councilor Ludke. So based on that, I'll take that as fact. we should have sponsorship of these two counselors to sponsor legislation to require our airport to opt not to use the PFAS-laden foams since they're allowed
Excuse me.
to not use them.
We'd like to stay on focus.
Yeah, but
this
I mean, it's-
evening. On this meeting is about the preliminary findings of the PFAS study.
But
And
because-
we will stay on focus. We will stay on track if you don't mind. And Dr. Shady, would you like to answer the question that he asked initially before we move on to another question?
It is pertinent, though, because the wellheads and the airport are neighbors to each other. And so if there's still PFAS foams being used in that location, it's taking the problem that we're trying to focus on here and continuing to make it worse after we got to a place in 2016 where we went to clean up the water. So our Hyannis ratepayers are a very small group of people. We're paying to do that cleanup of that water in our enterprise account. If the airport's still putting PFAS foams into the ground, it does seem pertinent to this situation.
So this,
Thank you.
so this question did come up at the last session, and one of the answers that came out of that discussion was that in the past, when the firefighting foams were used, that the foam would run off into the ground, and that now the foam is being contained. I can definitely get back to you with more information about what we know about what is currently being used at the airport.
Yeah, I'd appreciate that. The cap on the Fire Training Academy is a containment, but the plume is still moving, both from the Fire Training Academy and the airport. So, two quick follow-ups. One, just a quick comment. In addition to your list of products, one of the most insidious products out there that has PFAS, dental floss. And I only went to the dentist just a handful of months ago, and they gave me dental floss. And then I don't even have an iPhone or smartphone, but I went on the laptop and I looked it up. The exact one they gave me, laden with PFAS.
So, yes, I know. So Oral-B Glide dental floss and other flat, ribbony dental floss is basically made with Teflon. And so one
Yes.
of our recommendations, not to stop flossing, you should still floss. But there are wax dental flosses. It's a perfect example of what we call kind of the essential use framework. So figuring out, are there places where PFAS don't need to be used, where we have ready substitutes. So microwave popcorn bags or dental floss is an example where we have other substitutes where the chemicals are not serving an essential function, and we have things that we can replace them with right now. So I hold up the dental floss as an example of that. There are uses like the firefighting foams where it's serving a useful purpose, but we do have alternatives, and we should move towards swapping them out. And then there may be applications right now where we don't currently have a substitute, and the PFAS are serving an important use. For instance, medical devices. And we should move for the other categories where they're not needed. Those are sort of the low-hanging fruit to move away from PFAS, and then also working towards alternatives for that third category in the future so that, that we don't need PFAS for those purposes either.
And last question, to try to get to, and I really appreciate your section there where you explained the 06 date, because I myself have really studied this a lot, because I sat up there for 12 years until I hit my term limit on the city council when we first bought this Hyannis water system. And when we first discovered the fire training foams at the Fire Training Academy and the PFAS. I was one of those city councilors up there. So I've studied this a lot. I was confused about the 06. I thought the 06 was when we first detected it, but you explained that that's really just a date that you went back from the study 15 years.
Right.
So I appreciate that. That gave me a good clarification. But focused on that, what date then, after 06, but heading towards 16, and 16, of course, was when we did the cleanup, as you explained very, very well. What was the date that we actually, as a city, owning the Hyannis water system and managing it through a private firm, what was the date that we actually began having the known high levels of PFAS?
So we don't know because we were the first to test for PFAS in 2009. We only tested for 3 wells. We were doing a Cape-wide study of public water supplies. So that was, and we didn't even test one of the Mary Don wells. The focus was not on firefighting foams. We were more looking at wastewater and other potential sources of emerging contaminants more broadly. So before 2009, we have no data other than our measurements in 2009. The next data that we have are from 2013 to 2015 with the UCMR data. As part of this study, we are working to reconstruct what we think the past levels were in the Hyannis water system. So we don't know exactly, we don't have measurements, but we can model when we think firefighting foams first started to be used at the Fire Training Academy, and modeling the groundwater flow to estimate when those would have first reached the Hyannis wells, and to estimate the levels in each of the well fields over time.
My recollection, yeah, I know, I understand. But the 2009 is the key date, because that's when we made the Fire Training Academy close or stop using the foams. Yeah. I know, I'm just trying to be...
I'm sorry, everyone. I really do feel that it's important that every person have an opportunity to ask a question, whether they're on Zoom or here in public. Now, Dr. Shader, if you want to go on with this, that's fine, and it's up to you, but there are a lot of people that have questions here.
Yeah, well, let's take some other questions, and then I'll be around afterwards to answer questions as well.
Sure. So we have a question about the causal relationship between PFAS and high cholesterol. I know you spoke a little bit about different health effects that can be related to PFAS, and if you could go into a little more depth about high cholesterol if you're able to.
I don't know that much about it. I'm looking at Abby, who's one of our postdoctoral researchers. My quick, maybe somewhat naive answer is that the structure of a PFAS molecule looks like a fatty acid to our body, so it's thought that that might explain to some degree how PFAS can affect our metabolism. Abby, do you have any? And you need a mic if you're going to add to that. Abby's one of our postdoctoral researchers and did her PhD work on PFAS toxicology.
Yeah, I think just for what is known about the associations, it's generally the LDL cholesterol that tends to be higher in association with higher PFAS levels, although there are some mixed results depending upon the population and the particular PFAS that are elevated. Total cholesterol has also been seen to be elevated more consistently in association with PFAS, and potentially has to do with some of those, when you hear about lipoproteins, that's the, getting into the messy details a little bit, right. I think that's the key information that is known. There's still a lot to be worked out at the molecular level, I would say, but the general associations are higher LDL or total cholesterol in association with certain PFAS. Sorry if that's not satisfactory.
Thanks, Abby.
So I know you agree with this, Dr. Shader, that this afternoon at the presentation, just before the end of the presentation, I asked Nadia from ERG, Eastern Research Group, and I asked Captain Tara Summers if they had anything to say about the work that we're doing, and to thank you very, very much for being here and supporting this effort. And we will try to stay focused on the study, of course, for the rest of the meeting. But do you have anything to say, Captain?
Well, thank you very much. I'm from the Agency for Toxic Substances and Disease Registry, along with Chris Mugford, who's here with me. I think what we'd like to say is really thank you to Silent Spring and all the partners that worked really hard to make this study happen. ATSDR is supporting the 7 study locations and the Peace Trade Port study, which is one of the first studies that launched. And I think the information we'll glean from this when all the data is in, it's going to help answer some of these community questions that you all have about what this exposure means for communities. And there's many, many communities around the country who are facing similar questions and challenges with PFAS and drinking water. So I think this is really groundbreaking work that you've all helped contribute to. So I'd just like to thank you for that.
Thanks. And I'm Nada with Eastern Research Group, and I am part of the team that's been working with data collection and now on the data analysis. And I echo what you said. I think, and Laurel did a great job of presenting the results of the preliminary results. And I think the key takeaway is that there's a lot of work to do, but we couldn't be where we're at without everyone who participated in the study. So I want to thank you for participating and asking the good questions and asking the hard questions.
We'd like to hear from Emily, who played a big role in the study here on Cape Cod and is also helping in air. Emily, do you have anything to say?
Oh, sure. I thought I was just going to be reading some more questions out, but I can say a few things. I was privileged to join this project partway through and kind of jumped in as we were just getting our other site out in air, Mass, launched. So I came to Hyannis to learn how things were done here and tried to kind of replicate that in our other community. I learned a lot, got to speak to a lot of people in the community and our research staff, as well as people from Eastern Research Group, like Nada, who's here with us today. I just wanted to say I'm grateful to be part of it. And I look forward to being able to share more results with everybody as we progress with the data analysis.
Thank you, Emily. Another question?
We do have a couple more, and please feel free to cut me off if we need to stop. We have one question. I hope I'm understanding this correctly, but it's about how PFAS chemicals move through air versus through drinking water. So the example that was given was from the Fire Training Area 1 plume at Joint Base Cape Cod. I believe the question is, are the chemicals moving through the air as well as through the water? And what can you tell us about other exposure routes besides drinking water?
All right, great question. So in areas like around Joint Base Cape Cod, where the firefighting foams were used in the past and the contamination is in the groundwater, I would think that most of that movement would be occurring as the PFAS are moving through the ground. There can be interactions between the groundwater and ponds, and there are places, because of the chemistry of the PFAS, they can accumulate kind of at the surface where the water meets the air, and there can even be like foam that sort of appears on the surface of the water in ponds with high levels of PFAS. But I would think that the most likely route of exposure could still be through drinking water. In terms of other exposure pathways, so some PFAS, based on their chemical structure, prefer to be in water, but some are what we call volatile, so they are nonpolar, so they're non-charged and they tend to be in the air. And so we can be exposed to PFAS that are volatile in indoor environments, so perhaps from the carpets or the chairs or from other products that contain PFAS. Some of the PFAS can end up in the air that we breathe in. And then in our body, they can actually be transformed. So like with slight chemical alterations, turned into things like PFAS or PFOA or other PFAS that we know the most about and have the highest level of concern in terms of health effects. The atmosphere is also a way that PFAS can move around the world globally. So at lower latitudes where the air is warmer, the PFAS can end up in the air, not the town of air, the air, atmospheric air, and move to more northern latitudes. And then the colder air, closer to the North Pole, can't hold as much of the chemical in the air. And so the PFAS end up in the local environment. So there's sort of a movement from lower latitudes to more northern latitudes. And this is not just for PFAS, this is for other persistent organic pollutants as well.
Thank you very much, and thanks for this comprehensive presentation. So if I do some research to find out what I have in my house that is likely a contributor to PFAS or contains PFAS, and I want to clean house, purge, do I take my dental floss and Teflon pans to hazardous waste collection, or do I throw it in the transfer station? Thank you.
Such a good question. I get this question a lot. What do I do with my pans if I don't want them? Or what if I want to throw out my couch because it's Scotch Guard treated and I don't want it in my house anymore. What's appropriate to do with that? I mean, regulatorily speaking, you don't have to consider those hazardous waste. You can just put them in your trash. I don't think a hazardous waste site would take household items like that. But I think it just raises this really big question, and it's a lesson I hope that we learn more broadly, that putting toxic, extremely persistent chemicals in consumer products just isn't a good idea. But no one's really come up with a good solution for what to do with the products that we already have in our homes. Thanks for raising that question.
Respect the time. One more question.
Sure. We had one more question on Zoom about PFAS blood testing. And just in case others have questions about PFAS blood testing resources, there was a slide that addressed this, and I can put a link in the chat on Zoom as well. This specific question is if people want to get their PFAS blood tests because of concerns about exposure through the contaminated water, is there any mechanism in which the companies that cause the pollution will help cover those costs? For example, the companies that made the firefighting foam.
I'll point out I'm more on the scientific side rather than the legal side of things. I think that there are class action lawsuits out there. I really don't know much about them. I think in terms of trying to get a company to pay for your PFAS blood test, I think that is kind of unlikely. I do know that the state of New Hampshire, this doesn't get the ultimate the manufacturers of the PFAS to pay, but the state of New Hampshire does require insurance providers to cover the cost of PFAS blood tests. As far as I know, that's the only state that has that requirement. It would be great to see that offered in other places. But in terms of just beyond the cost of blood tests, I think of all the costs of water treatment and all the other remediation costs. It's hard to pass those costs along to the companies that profited from the production of these chemicals. I will add that EPA recently added PFAS and PFOA to CERCLA, which is the Superfund law. And so for the first time where there's contaminated sites under the Superfund law, there may be mechanisms now to get polluters to pay for the cost of treatment or remediation of contaminated areas. But I don't know an easy way to have the companies pay for the cost of PFAS blood tests, but an important question.
Let's take one more question. Emily.
Okay. One more question. So this is referencing a graph in the presentation. I'm not sure which graph it is, but I think it's asking if PFAS levels decline over time. Does that mean that the body is clearing PFAS over time, or does that mean that PFAS is getting stored elsewhere in the body, or does it just mean that people are growing older and dying and then they're no longer part of the picture that we're looking at? If that was clear. That's a complex question.
So PFAS are difficult for our bodies to excrete. So while we're continue to be exposed to PFAS, the levels of PFAS in our blood kind of build up over time because we're taking them in more quickly than we're able to excrete them. So if we are able to stop that exposure, then over time the levels in our blood will go down because we're excreting the chemicals more quickly than we're being exposed to them. There are concerns about where else in the body PFAS may be stored, and the answer to that question may be somewhat chemical specific. I've seen one study of laboratory animals where they looked at radiolabeled PFAS of different chain lengths, and those PFAS did accumulate in different patterns in different parts of our body. But I would say that the graph that showed the declining levels of PFAS and the other PFAS in the general population represents a decreased exposure, and then our bodies are able to lower the PFAS because we're excreting them more quickly than we're taking them in. Yeah.
Well, thank you very, very much, Dr. Shader. It's such a pleasure working with you. You've worked so very, very hard. And I know that a lot of people have a lot of questions about other issues pertaining to PFAS, and I feel badly when I have to cut them off. But I think it would be important if you can come back at another time so we can sit down with people in the community to talk about other issues. But tonight it was important that we stay focused on what this meeting was all about. And I want to thank everyone who came here to hear about the preliminary results of the study. We couldn't have done this work without our town officials, the media, Captain Summers, our study team, our volunteers, and all of you here tonight who care deeply. This isn't goodbye. Let's get together soon. Call me, email me, and Emily, could you let people know how they can send in questions if they have more questions?
Sure. So if you have any additional questions, you can speak to us afterwards. And you can also reach out to us at our study email, which is PFAS, PFAS-health-study@silentspring.org. And we'll get back to you.
Perfect. And I just want to remind everyone why we're here, really and truthfully, for our children, our grandchildren, and future generations. Thank you for caring. Have a great evening. Thank you.